Okay, Dr. Ouellette, I believe we are ready to begin.
Great. Hello, and everyone. I'd like to welcome you to our colorectal cancer webinar. On behalf of Premier Health and Premier Health's cancer team, I would like to thank each one of you for attending this evening. We're very glad to have you with us. My name is Dr. James Ouellette. I am a surgical oncologist with Premier Surgical Oncology and also with Premier Health's cancer physician lead. Tonight, we are here to discuss cancer of the colon and rectum. We may see this termed colorectal cancer. All of these are essentially the same meaning. And as you know, or at least you may have heard coming into tonight's discussion, that colorectal cancer is on the rise in the United States, especially in our younger population. It is now the third most common cancer in the US. However, with screenings and early detection, chances of recovery and survival are greater than ever before. Our speakers tonight include Dr. Marinella, Dr. Abudh, Dr. Reed, Dr. Depker, and Mickey Clancy. They will all be sharing some vital information tonight about colorectal cancer, and this will range from prevention, genetics and screening, to treatments and support services that are offered here at Premier Health. For the next hour, each of our speakers will give 5 to 10-minute presentations. Following all of the presentations, we will then have a question and answer session. To submit a question, please use the Q&A button at the bottom of your screen and type in your question. There may also be a chat button on your screen, but please disregard that. All questions should be submitted by the to the Q&A button. Feel free to send your questions throughout the presentation, and we will try to get to as many of the questions as possible tonight, in our allotted time anyway. We will also be recording this session to be able to share with everyone later. So let's start off our evening by introducing our first speaker, Dr. Mark Marinella. Dr. Marinella is a medical oncologist with the Dayton Physicians Network. He graduated from Wright State University School of Medicine. He completed his residency at the University of Michigan Medical Center and his fellowship at Wright State University. Dr. Marinella is also an MD Anderson Cancer Network certified physician here at Premier Health. Welcome, Dr. Marinella.
Thank you very much, Dr. Ouellette. Thank you for the opportunity to give a 30,000-foot overview in 8 to 10 minutes on colon cancer, colorectal cancer. I'm going to give just some real basics on some demographics, workup, treatment, and then hopefully that'll give you a good overview. So move on to my first slide here. So just an overview, as Dr. Ouellette was saying, there is an increase. And currently in 2020, these data are from last year, there were about 80,000 cases of colorectal cancer in men, and approximately 70,000 in women. And this accounted for about 9% of all cancer deaths in men and 8% in women. So it's pretty close, although a little higher incidence in males than females. As Dr. Ouellette was saying, this is the third leading cause of cancer and cancer deaths in men and women as of 2020, with colon to rectum, and I'll explain what the difference is, because even though the colon is a long tube, colon cancer is different than rectal cancer as far as treatment, evaluation, and prognosis in some cases. But there are about 2 cases of colon cancer to rectal cancer to 2 cases of colon to 1 case of rectal cancer. In a male's lifetime, there's approximately 1 in 23 chance of contracting colorectal cancer and about a 1 in 25 chance in women, whereas breast is about 1 in 8 or 1 in 9. Incidence increases with age, like a lot of cancers do. However, also, as Dr. Ouellette alluded to, there is a disturbing increase in young people, especially at the age of 40. And I have seen my share of patients in their 30s and 40s. Nobody really knows what it is. Next slide, please. So as I mentioned, and I think Dr. Depker will touch on this more than I do. He is a surgeon, I am not. But basically the colon is different than the rectum from an anatomy standpoint. You know, as far as what we characterize as a rectal cancer, yeah, it's probably the last foot or so of the intestine, but it's defined by a surgeon by the peritoneal reflection, which is a piece of tissue inside of the abdomen from the all the way down to the anal region. But in any event, the colon and rectum come from different parts during development, when we're developing as embryos. And now we've even found that colon cancer on the right side versus the left side are different diseases and behave differently and are treated differently. So this has evolved, especially in the last few years, right versus left. But to keep it simple, colon cancer is treated a little differently than rectal cancer, as we'll see. But there's a cartoon showing the different parts of the colon and the rectum. Next slide, please. So risk factors for colon cancer, and I think this will be discussed in a few minutes on risk factors and genetics, but overall, there are some hereditary syndromes. One is called Lynch, one is called familial adenomatous polyposis. If you have a first-degree relative like a mom or dad or brother or sister, the risk is also elevated, but not to the degree as a genetic syndrome where it's actually passed in the genes like Lynch syndrome. A history of polyps, probably a higher risk of colon cancer, colorectal cancer in people who eat high-fat, high red meat. High red meat. A little bit of red meat doesn't necessarily increase your risk, but there is a link. People who eat more plant-based diet, more plant-based foods, and even geographically in certain parts of the world, colorectal cancer is less common. So there does appear to be an inverse relationship between the amount of plant-based diet and the contraction of colon cancer in life. Obesity, smoking are risk factors. Inflammatory bowel disease, Crohn's disease, ulcerative colitis also increase the risk. Physical inactivity. And then the microbiome, one word on that. The microbiome is a population in the gut of viruses, bacteria, and fungi that is in the billions and billions of these organisms. And what's called an adverse or dysbiotic microbiome, which means there's some funky bacteria that shouldn't be there, probably increase the risk of colon cancer too. And it is felt that this might, based on diet, be one of the contributors to the rising incidence in people under 40. So diet does play some important role in protecting against colon cancer. And then lastly, coffee has been shown to potentially decrease the risk as well. So those are some dietary things. New slide, please. So symptoms of colorectal cancer, what we're hoping is that people will ultimately get screened and be diagnosed without symptoms, because a lot of cases are not symptomatic until very, very late, or hopefully picked up on screening. But some common symptoms that we hear, changes in bowel habits like constipation, diarrhea, especially if someone hasn't had those problems, changes in the size of the stool, blood, of course, pain with defecation, or even abdominal pain. Weight loss and loss of appetite usually occur later if the cancer is advanced or spread. And then if it is spread to the lungs or to the spine, for instance, patients might get a variety of other symptoms. So if there are symptoms, sometimes that means that the cancer could be advanced. Next slide, please. So as far as diagnosis, colonoscopy, which will be talked about, as well as biopsy. What's important now is that we're doing genetic studies on just about everybody. So all of these things we do here at Premier, all of the state-of-the-art genetic testing. One of them is called Braf, another one's called microsatellite. So those are important to test. DNA stool testing, I won't talk about. If somebody is diagnosed with colon cancer, we also do CAT scans to make sure it hasn't spread. There are some blood tests we do. One is called a CEA level once somebody is diagnosed to see if it potentially is spread. Rectal cancers, there's image differently. So somebody has rectal cancer, we do an MRI. which Dr. Depker will discuss, and something called an endoscopic ultrasound. So I guess the point is rectal cancer, you get a couple of tests in there. Please. So as far as staging, there are 4 stages, and keep it simple. If it's stage 4, that means it's another organ. If it's stage 3, that means cancer in the colorectal, also lymph nodes in the same vicinity. Stage 2 means no lymph nodes, but it's halfway through the wall. Halfway through the wall. And stage 1 means it's less than halfway. So for stage 1 and 2, the size doesn't matter, which is unique to colorectal cancer. It's how deep it is through the wall. New slide. So treatment of local colorectal cancer. If it's colon cancer, and these patients usually start out with a gastroenterologist, they have a growth, they will often get sent to a surgeon, they'll get their scans. If it hasn't spread and it's localized, surgery is first, that is standard. And then they come to see myself or a medical oncologist who may recommend chemotherapy if it's in the lymph nodes, which would be stage 3. If it's not in the lymph nodes, then most patients do not benefit from chemotherapy, although there are some exceptions, which I won't get into. Next slide. As far as rectal cancer, this is a little trickier because of the anatomy of the rectum and the way that this disease behaves. But if someone gets a rectal cancer, they're going to see a few doctors, a radiation oncologist, a surgical oncologist, and a medical oncologist. So it's a team effort for rectal cancer. May involve chemotherapy and may involve radiation with chemotherapy before surgery. So it's important to see all of these specialists before starting on any treatment if someone is diagnosed with a colorectal cancer. But the other important thing is surgery by a qualified surgeon, a surgical oncologist. This is a tricky surgery, as you will hear, and usually a surgical oncologist is the best person to perform this operation after chemotherapy and radiation. Next slide, please. And then about at the end here, so as far as drugs, and that's what I do, I give chemotherapy and other medications. Generally speaking, for stage 3, if it's in the lymph nodes, that would be 3 to 6 months of chemotherapy. The classic regimen is called FOLFOX. That's 3 different medications, requires a port, and going home with an infusion every 2 weeks. There's another regimen you use, which is a combination of oral and IV. But if it's stage 3, bottom line is 3 to 6 months of chemo. For stage 4, that slide on the right should say stage 4, which means it is spread to other parts of the body. We use chemotherapy. We use things called antibodies that are not chemotherapy that improve the effectiveness of the chemo. There's a variety of oral drugs that we can use. And then for select cases, immunotherapy. And then clinical trials are always potentially important. So on the right, that should be stage 4, not stage 3. Next slide. So side effects of treatment, because people are worried about this. You know, some of the side effects of chemo, of course, can be vomiting or diarrhea. We're good at preventing vomiting. Low blood counts, fatigue. Some of the other drugs can cause diarrhea, rash, blood pressure problems. Immunotherapy, there's a lot of potential side effects, but generally well tolerated. And for some patients, immunotherapy like Keytruda or other drugs can be a game changer for stage 4 colon cancer. And then there can be side effects of radiation. Next slide. I think it's the last one. So that's a lot in 8 or 9 minutes, but I thank you for listening.
Thank you very much, Dr. Marinella, for a wonderful overview and cramming that into a 10-minute time frame. Excellent job. Thank you very much. Next, we have Dr. Fayez Abudh and Dr. Kenneth Reed. They are both gastroenterologists with Premier Gastroenterology. And Dr. Abudh graduated from medical school in Ain Shams University in Egypt. He completed his residency at Kettering Medical Center and his fellowship at the University of Western Ontario. Dr. Reed received his medical degree at the West Virginia School of Osteopathic Medicine and then subsequently completed his residency at Ohio Health Doctors Hospital. He then completed his gastroenterology fellowship at St. John Macomb Hospital in Michigan. So I want to welcome Dr. Abudh and Dr. Reed, who will take on our gastroenterology section.
Next slide. So me and Dr. Abudh are going to kind of break this up a little bit. I'm going to start off with talking about prevention. Dr. Marinella sort of took some of my thunder away, but that's okay. He went over all the risk factors for colon cancer, and one of the risk factors is family. You can't pick your family. What genetics they give you is what they give you, but there is a lot of stuff that happens in our daily lives that actually can prevent colon cancer. We know that people that are overweight and they're diabetic are at increased risk for colon cancer. We know that they have more precancerous polyps, and if you have more precancerous polyps, you tend to develop cancer. So if you can achieve normal weight, if you can lose weight, that helps with preventing colon cancer, along with many other diseases that we deal with. We know that people that are sedentary, that are couch potatoes, tend to have more of a risk for colon cancer. So if you can get active, I think the new guidelines are 30 minutes a day for 5 days a week or something like that. But any kind of activity, increasing that up will help, or at least will hopefully help prevent colon cancer. Diet is a big one too. Increased risk of red and processed meats. We eat a lot of processed foods, a lot of refined carbohydrates. So if you can increase up your amounts of fruits and vegetables and dietary fiber, that can prevent colon cancer as well. Smoking, I had a partner that used to call smoking polyp food. I tend to see a lot more polyps and colon cancer in people that smoke, along with all the other bad things that go along with smoking. If you can quit, then that is known to prevent colon cancer as well. Decreased alcohol use, alcohol in moderation is fine, but too much is a risk factor for colon cancer. Aspirin use, I put this down there. They've looked at different medications, things called non-steroidal anti-inflammatories. Dr. Marinella mentioned drinking coffee as well, which I did not put down. But right now, there are some places in this world where they will recommend aspirin. I've seen doctors use aspirin or what have you. There are some studies that say that it does help, and there's some studies that say that it doesn't help in older adults. But so right now, I can't really recommend that. I put that down there, but I wouldn't go out and start taking aspirin unless you had talked with your doctor about that. Next slide. So again, we can't pick who our relatives are and what kind of genetics we get, but colon cancer is a play between the genetics and the environmental factors. If you're going to pick two things to try to really work on that could help you to prevent colon cancer, it's really your diet and your lifestyle. If you're overweight and you're sedentary, those are the two biggest things. 35% of all cancers, not even including colon cancer, are attributable to diet, and 50 to 75% of our colorectal cancer deaths or colon cancer diagnoses may be preventable through dietary modification. So that's a pretty big number there. So again, if you can cut out the red meat, cut out the sugary meals, the processed food, then you can cut down your colorectal cancer risk. Next slide. So this is a slide kind of looks at kind of how we split up who gets cancer. So if you look at over to the right there, 75% of people don't have any family histories at all. They're what's called sporadic. They can't tell us anyone in their family that has it. And then there's about 15 to 20% of people, they have probably someone in their family that has it. It may not be a close relative. It may be an aunt. It could be a grandfather, and still puts them at risk. But it's not the main bulk of colon cancer. And then there are some people that actually have a hereditary syndrome, and Dr. Marinella mentioned Lynch syndrome, FAP. These are people, if you look at their family tree, they have successive generations. mom had it, brother has it, grandfather has it. And they had, a lot of these people have this early in life, below the age of 50. One of the excuses I do get from people quite a bit is they will say, well, I don't need to have a colonoscopy. I don't have a family history. And that's probably one of the biggest excuses I get. And again, looking at this slide, 75% of these people don't have any family history at all. And this is a disease that hits, white people, Black people, rich people, poor people, men and women. It's indiscriminate. As physicians, we are bad at looking at someone and saying who needs to be looked at and who doesn't. So we really try to get everyone we can to get looked at. And Dr. Abudh's going to go into all that stuff soon. So next slide. Again, this is talking about familial. These are the people that have, they may have a relative, may not be super close. Maybe they didn't have cancer at 30 or 40, but they had, cancer over the age of 50. Maybe they have some relatives that are younger, but maybe it's not every generation. Maybe there's, maybe an aunt here, a great grandfather. But still, they have a family history. We still try to pay attention. We pay attention to everyone, but we still kind of keep them on our radar. We still try to watch them closely to make sure that they don't develop cancer. Next slide. And again, this talks about, looking at these people early. If you have someone that has these, that has a family history, maybe not the strongest family history, but they have it, they don't have one of these syndromes like Lynch syndrome, we still look at them. We like to start looking at their colons, doing colonoscopies at age 40. If they say they got colon cancer at age 35, like a mother or like say they got a grandfather that started at age 35, we may bring them in at 30 or 25 if we can. Now, some of these people are older. When they come in, their family members, they don't think about getting a colonoscopy, or they don't, or their family members, it was a while back or what have you. So again, we watch these people closely. Next slide. And then the genetics. And again, Dr. Marinella touched on these. These are the people that have multiple relatives with colorectal cancer. They're diagnosed at an early age. Sequential generations, multiple family members. And then, they've got other cancers too. They get ovarian cancers, uterine cancers, other different cancers, and they have to be looked at as far as that goes. And again, they get multiple tumors in different places. Next slide. Dr. Abudh.
Okay, thank you, Ken. I will welcome everybody and thank you for taking the time to hear about colon cancer tonight. My role here is to talk about screening, and I'll try to move fast initially, give you an overview, and then there will be time for questions at the end. The term screening means testing individuals with no symptoms of a disease to detect early cancer. And in colon cancer in particular, it detects early cancer, obviously, but it also prevents cancer. And this is possibly or likely unique to colon cancer because we can remove colon polyps. And by removing colon polyps, we prevent colon cancer from ever starting. All colon cancers, most or the vast majority of colon cancers, with few exceptions, start as a colon polyp, which is the little seed that grows to become colon cancer. And it takes, the good thing is these polyps start small and take few years usually to grow into a cancer, giving us time to look and remove these polyps and prevent cancer of the colon to start with. Who should be screened? We'll talk about this again more, but it used to be, and we all heard about the age 50. This has been lower recently, and the general recommendation is starting screening at age 45. The important point here that was just made by Dr. Reed is that you do not have to have a family history. The average risk person is somebody with no risk factors. Most of the colon cancers start as in patients without family history of colon polyps or colon cancer. So there are different ways to look at screening, and the best screening test for any cancer is the one that's available, that's inexpensive, that's accurate and safe. However, the best test is the test that gets done, because we can talk about all tests, and if nothing gets done, then we all lose. So you have to do something. What test? A discussion should be made with the primary care provider, and the options are discussed. So one way to look at screening for colon cancer is a two-step test, one-step test, and two-step screening test. The one-step test is the colonoscopy. It's the only test that can remove the polyps at the same time and prevent colon cancer, and it would obviously diagnose early colon cancer as well. The two-step test is a stool test. This would be followed, if positive, by a colonoscopy. So a two-step, the second step is the colonoscopy. So again, it's important to say that the best test is the one you get done. So if you don't want to do a colonoscopy, just do something that needs to be done. So next slide, please. The colonoscopy is the one step we talked about. It is the most accurate test that detects and remove colon polyps. It's a very common procedure, as you all know, and it's the most common endoscopic procedure done in the United States. It offers removing of the polyp and prevents and decreases mortality, risk of dying from detection of colon cancer. Next slide, please. The way colonoscopy prevents colon cancer, we remove polyps during colonoscopy. And this is a diagram that just illustrates how a colon polyp is removed through a colonoscopy. You can see this looks like a little mushroom or a stem of broccoli, and we put a loop of wire around it, like we call a snare, and it chokes the polyp, and a current is ran through that wire to cuts it off, and then the polyp is retrieved and sent for biopsy. Now the polyps come in all shapes and forms and sizes. On the next slide that's coming up here, I will play a short video that shows you how a polyp is removed during the colonoscopy. The video will show the inside of the colon during a colonoscopy. It's a 1 minute and 8-second video. If you prefer not to, it's very educational. It will give you a good idea how things are done, and nice to watch. But if you prefer not to see it, you can look away for 1 minute and 8 seconds, and I will let you know when to look back. So let's play the video. Thank you. This is inside the colon. This is a good prep. The colon is cleaned out, and here's the polyp, that bump you see at the bottom of the screen at 6 o'clock, and you will see the scatter, the tube, and here's the snare or the wire loop. We put it around the polyp, we choke it, and the current is ran. You can see the white at the bottom of the polyp, and the polyp is cut. And then this polyp will be removed and retrieved. And it will, in this case, is removed by suction. It just removed, and this little small defect where the polyp is removed, this is magnified. And this will heal over, and then when we look again at a later time, you don't see where the polyp is removed usually. This polyp probably was the size of a small grape, or maybe smaller than that, and it's a common polyp that we see on a routine basis, as we do on daily basis. And the colon, as you see, is very cleaned out, and this is such an essential part of the procedure. The video is over if you wish to look back. So this was colonoscopy as the one step, and it's the best way to screen for colon cancer. And a colonoscopy is used for screening in the average risk person. That's a person without family history of colon polyps or colon cancer or other risk factors, and it's done every 10 years. So if you have a good quality colonoscopy, which means that you're cleaned out good and had a good quality colonoscopy done with appropriate withdrawal time and an appropriate look in the colon, then, and if you have no polyps at the time, then you can come back in 10 years to have another colonoscopy. Now, if you choose not to do a colonoscopy, then a two-step screening is the option. And there are two ways of doing that with stool test. One is called the FIT, or fecal immunochemical test, and one is called the multi-targeted DNA test. The FIT test is a stool sample to check for blood. You may be familiar with the older one that people used to send 3 cards. They get and send in the mail. The mailman usually didn't like that. It's the old called Hemocult or Guaiac test. These are not done anymore. The newer test is the FIT test. It detects blood, hidden blood in the stool. A stool sample is sent, and it detects 70% of the cancers, only 30% of the polyps. That's why the colonoscopy has advantage, but it is a good test to be done. Again, the best test is the one that gets done. The only thing is, if this test is chosen, it has to be done every year for it to be effective to eventually prevent or detect early cancer. Is to be done every year if the FIT test is chosen. If a positive test occurs, then a colonoscopy should be done. It may be a false positive, but it may not be. So that's if it's positive, then a second step or a colonoscopy is done. Next slide, please. The next one is the multi-target stool DNA test, which had a lot of publicity in the recent past. It's commonly known as Cologuard. It's better as detecting cancer, but however, the flip side of that, there is more false positives. That means the test can be positive, then you get a colonoscopy and there will be nothing there. So it can be a false positive test. So if it is positive, a screening, a follow-up, not screening, a diagnostic colonoscopy would be done to see what caused the test to be positive. If the Cologuard test is chosen as a method of screening, it should be repeated after every 3 years. And one very important point in this test, it is not indicated in a person that is at high risk. If somebody has family history of colon cancer, family history of significant or advanced polyps, then should not have the Cologuard. They should directly have a colonoscopy. That's a different issue. That's screening in the high-risk patient. We can go to the next slide, please. So the stool test colonoscopy. However, the best test, if you're not going to do a colonoscopy, so the current new guidelines by the American College of Gastroenterology is colonoscopy is recommended as the method for screening for ages 45. Now that's been lowered from age 50, age 45, certainly, or especially for African Americans, for males and females of all sexes, starting at age 45, colonoscopy every 10 years if negative. If a person is unable to, does not wish to have a colonoscopy, then the current recommendation by the American College of Gastroenterology is to do a stool FIT test once a year, every year, and if positive, proceed to colonoscopy. Now, if colonoscopy is done and it's considered a quality colonoscopy with a good preparation and adequate visualization, then there's no need to repeat the stool test every year after that. Some argue you can start doing it at 5 years, but that's not the standard of care. These tests, the Cologuard and the FIT test, are not replacement for in high-risk individuals. Somebody with family history or other risk factors, including inflammatory bowel disease and other risk factors been mentioned already, do not qualify for the routine tests we just mentioned. Next slide, please. That's all for now. I'll be happy to answer questions at the end. The take-home message is, at age 45, start doing something, discuss with the primary care provider the options, and the hope is to prevent colon cancer before it starts, or if you detect it early, you can be treated, and you will see shortly the advanced, wonderful techniques available through our premier surgical oncologist and their team. Thank you.
Well, thank you very much, both Dr. Reed and Dr. Abudh. You'll be happy to hear that I have had my colonoscopy within the last year. We will go ahead and move on to our next speaker, and that is Dr. Matthew Depker. Dr. Depker is a surgical oncologist in my same practice of Premier Surgical Oncology. He is another graduate of Wright State University School of Medicine. He completed his general surgery residency at Good Samaritan Hospital in Cincinnati and completed a fellowship in complex surgical oncology and also a research fellowship in gastrointestinal and cutaneous oncology, both of which at the H. Lee Moffitt Cancer Center in Florida. Dr. Depker is also a certified physician through the MD Anderson Cancer Network, and I'd like to welcome Dr. Depker.
Next slide. Well, thank you for the opportunity to present and talk with you tonight. The goal of my talk is to discuss the surgical options available in patients who are diagnosed with colon cancer. Next slide, please. I feel that the most efficient and seamless way to do this is to do it through a case-based presentation. So I'm going to present a patient. He's a 55-year-old male who underwent his screening colonoscopy with his gastroenterologist, and on that colonoscopy, they found that there was a polyp that appeared to be cancer in the descending colon. It was unable to be removed endoscopically, so a biopsy was taken, and that biopsy showed that it was a cancer. It was incompletely excised, so the patient was sent to our office to discuss plan and potential further surgery. So when I see patients in the office who have a polyp that is a diagnosed cancer, I always get a CT scan of the chest, abdomen, pelvis. The reason I do that is because patients, about up to 20%, can present with metastatic disease. And what that means is that there may be disease outside the colon, commonly in the liver, lungs, or on the peritoneal wall. So it's imperative that a CT scan is done. Next slide, please. So I briefly want to review colonic anatomy. I know Dr. Marinella did this earlier. The reason I like to do this is because there's a couple different names for the parts of the colon that can be confusing. So in this picture, you see the ascending colon is blue. Excuse me, that's also known as the right colon. You have the transverse colon. You have the descending colon, or the left colon. That's our patient has his polyp in the descending colon. You have the sigmoid colon, which is just a continuation of the descending colon. And you have the rectum and the anus. And we're not going to get too much in depth on rectal cancer, as that's, as Dr. Marinella said, a separate entity, and we only have a limited amount of time. But I at least wanted to point it out on illustration. Next slide, please. So this patient, he underwent his imaging, and there's no evidence of metastatic disease. The cancer was seen in the descending colon. So we proceeded to discuss surgery. Next slide, please. So what are the treatment options for this patient? What type of surgery can be done? Next slide, please. So traditionally, we used to do open operations, which really utilizes just one large incision. More recently, we do what's called minimally invasive surgery. There's a lot of different names for these. So what I like to tell my patients is you either have an open surgery with one large incision, or you have a minimally invasive surgery with many small incisions. There is a illustration at the end of the talk that shows the scars. And although the minimally invasive surgery is cosmetically appealing, The open surgery does the same thing. And I want to be clear about that, that whether you get an open surgery or minimally invasive surgery, the goal at the end is to remove the cancer completely and make the patient cancer-free to give them the best survival. So whether you get an open surgery or minimally invasive surgery, the goal is to remove the cancer. Next slide. One thing that we do at Premier Health and is also done at major cancer centers around the country as well is we couple minimally invasive surgery with enhanced recovery after surgery, or ERAS protocol. Why do we do the enhanced recovery after surgery protocol? Well, the name states it. We want to enhance the patient's recovery and get them out of the hospital. Why do we want to do that? Our goal is not only to remove cancer, but is to return patients to a normal life, a normal way of living before they're diagnosed with cancer. Next slide, please. A little bit more information about the ERAS protocol. Again, we do it with all our patients who are undergoing minimally invasive surgery, whether that's laparoscopic or robotic assisted laparoscopic, and we'll touch on the difference between those in the next coming slides. But I wanted to touch on ERAS, as this is a popular question I get among my patients. So how does ERAS help the patient? Patients who undergo minimally invasive surgery, they have smaller incisions, they have less pain. Because they have less pain, we're able to use less narcotics. We spare using opioid narcotics. Why is that important? Because opioid narcotics slow bowel function. After surgery, we give them early nutrition, meaning they have clear liquids the night of surgery, and they have a regular diet the next day. Again, this is important. It gets them back to a normal way of living, a normal way of life. We increase their mobility. They're walking around, they're eating, their pain is better. And studies have shown that this decreases the hospital stay by about 30% or 2 days, and also decreases complications by about 40%. Next slide, please. So I mentioned earlier, when you have a minimally invasive surgery, it can be done standard laparoscopically or robotic assisted. And I wanted to touch on a robotic assisted surgery, mainly because this is becoming more and more popular, and we are doing more and more robotic assisted surgery at Premier Health. So if you look at screen right, you have the robotic console. That's where the surgeon sits. In the middle, you have the robotic arms, and then you have the tower. Next slide, please. So you see the surgeon, that would be myself or Dr. Ouellette, sitting at the console. The robotic assisted surgery, there is some advantages compared to laparoscopic surgery. Number one, if you look at the surgeon, he's sitting on the console, he's looking in a viewer, which is 3D, versus laparoscopic surgery is just 2D. The arms, if you look in the middle, hold the instruments. The surgeon controls the arms, and it's a 3D articulation, much like the human wrist. So overall, the surgery is hopefully much more seamless. Now, again, one thing I want to stress is there's no real oncologic difference between either an open surgery or laparoscopic surgery or robotic assisted laparoscopic surgery. And not every patient is a candidate, unfortunately, for a minimally invasive surgery, whether that is body habitus, medical comorbidities, or previous surgery. One thing I wanted to do with this talk is, because I get a lot of questions about robotic assisted surgeries, I wanted to show a video of what we see when we look into the console and how we operate. And that'll be at the end of this presentation. Next slide, please. So briefly going back to our patient, this is the surgery he needs. He needs a left colectomy. This goes by different names: left hemicolectomy, descending colectomy. Really, the point of this is to remove the colon with the cancer. We try to get negative margins, which means we have normal tissue on the top and the bottom, and the patient gets put back together through a series of sutures and staples. And I get a lot of questions about ostomy bags, and most patients who undergo a right, left, or transverse colectomy don't need an ostomy bag. And if they need an ostomy bag, it's temporary. Unfortunately, that's a little bit outside the scope of this talk, so I won't talk too much more about it. Next slide, please. I like this image because it's a little bit more realistic. You have the colon, there's cartoon tumors, but what's important about this image is that there is mesenteric fat, and within this fat, and you don't see it in this pictures, but there's lymph nodes. And those lymph nodes are removed with the colon. And the pathologist not only looks at the margins, but they look at the lymph nodes. And if those lymph nodes are positive, then that patient will need chemotherapy. And that's where Dr. Marinella and his team come into play. If the lymph nodes are negative and it's an early stage tumor, then the patient doesn't necessarily need chemotherapy, just surveillance. Next slide, please. This is what we mentioned before, where we have scars from the laparoscopic surgery and then scars from the open surgery. Obviously, the laparoscopic surgery are a little bit more appealing than the open surgery, but again, the result will be the same. Next slide. End result, the patient ended up having adenocarcinoma, colon cancer. All the margins were negative. 2 of his 25 lymph nodes that were removed with the specimen were positive. So he was referred to medical oncology for discussion. Next slide. Next slide. So just to illustrate, those are the instruments, robotic instruments. This is, as again, sitting at the console, as we mentioned before. We are controlling those instruments. At the bottom of the screen is a colon. There's just some embryology attachments that you see during development that Dr. Marinella kindly mentioned before. And you kind of see that the colon itself is the way that we develop is attached to the abdominal wall, and that's kind of slowly being what we call mobilized or brought away from that wall. This is obviously you can't see with this image, but it is a 3D viewing, which does help visualization and makes the surgery a little bit more seamless and easier in some places. Again, here where the scissors are being used to kind of mobilize that colon over and take down those attachments that form when you are developing as an embryo. Again, this is his left colon. And that's it. Thank you for the time to talk, and I'll take any questions at the end.
Thank you very much, Dr. Depker, for a wonderful presentation. Finally, we'll move things along as quickly as possible so we keep on time and get to any questions that are available. Please submit those if you need. Finally, we will have Mickey Clancy, who is Premier Health's Chief Digital Officer, present today. She has been with Premier Health for close to 30 years and served in many roles, including most recently the System Vice President for Oncology Services. So welcome, Mickey Clancy.
Well, thank you all for being here tonight. I am very delighted to teach you a little bit about the cancer program overall. Our website is right up here on the page, so you can explore. Probably one of the most interesting documents to tell you about the totality of our program is our annual report. And so if you go to that, you'll be able to see that. We have been working very closely with our partner, MD Anderson. That's one of the largest cancer centers in the world and usually ranked either #1 or #2 in the world for cancer services, to begin to continue to try to eradicate cancer. So a lot of what you've heard our physicians talk about tonight are things that we work together with MD Anderson to coordinate our care plans and take the already good care that we provide here and make sure that it's world-class care. And we work together to make that look and bring it here close to home so people don't have to travel to a place like Houston to have that cancer care done. We do provide the holistic care for all of the patient, not just the medical oncology or the radiation oncology or the surgical oncology that was talked about tonight. But we do have a full cancer prevention program, as well as many, many integrative services and supportive services. We have a wonderful patient navigation team that will help you through your journey. I'm a cancer survivor myself, and they were invaluable so that we could coordinate that care, so that it took a lot of pressure off of the family and the caregivers as we help make sure that you get all the care that you need when you're having your cancer services with Premier Health. We're quite happy and proud of the technological advancements that we've done. There will be an upcoming article in the Dayton magazine about the types of advanced surgery and advanced treatment and advanced screening that you can receive here at Premier Health right here at home and not have to travel anywhere else to get that done. So with that, I'm going to shorten my part of the presentation so that you all have an opportunity to ask questions. And I would be happy to answer any questions in the Q&A about our overall cancer program. So Dr. Ouellette, I'll hand it back to you. And thank you very much.
Great, and thank you very much, Mickey. Again, the information on the slide there hopefully will stay up there and be accessible for anyone who wants to write that information down. And of course, this presentation will be archived for people to address later. I've tried to look at some of the questions and give answers along the way, but there was an opinion question that was asked, and I think, well, everybody may have an opinion. I don't know if this harkens back more to the gastroenterology section. The question is, in your view, which of the following represents a higher risk? And that is a Braf mutation detected by pathology in a removed polyp, or a polyp removed fragmented where the margins are not easily identifiable. I don't know who wants to take that one first, or who has an opinion about it, but.
Fayez, do you want me, or do you want to take it?
I can say something, and as far as the Braf mutation, we can, maybe Dr. Marinella can give, I think the Braf mutation with the actual diagnosed cancer is one issue, and then this question refers to polyp. And I think the way that this is just recently being done on polyps, I think the pathologists use the Braf mutation on certain polyps. There are different, this kind of in the weeds type answer here, but there are different types of polyps. Traditionally, they used to be a hyperplastic and adenomatous polyp, and the adenoma tubular and villus, and over the past several years became more recognized as serrated polyps, and histologically under the microscope is not always easy to identify a hyperplastic polyp, which is not really it's not really a precancerous polyp, from a serrated polyp. And serrated polyp can look like hyperplastic polyp under the microscope, but it is significantly precancerous polyp. And the pathologists sometimes run this Braf mutations on the tissue to determine that it is a serrated polyp, which then for the gastroenterologist then determines what to do next. So if a polyp is removed completely, endoscopically determined by the endoscopist, and it comes back as a Braf positive mutation, it is a serrated polyp. We follow the guidelines by its size and whether it's removed in one piece or piecemeal. So the Braf part, to answer the question, the Braf part just identifies what type of polyp. We're not talking about cancer now. We're not talking about Braf positive cancer. We're talking about a polyp. And just the pathologist use this to identify a serrated polyp versus a hyperplastic polyp. And then, so if the polyp is removed in toto or in one segment, then it is completely done. We follow the guidelines as far as the size of the polyp, as far as what else was removed, the total number of polyps, and that determines when the patient comes back for a follow-up colonoscopy. If a polyp is removed in piecemeal fashion, it's not ideal. We are sometimes are forced to remove it in piecemeal because of the shape of it. It's bumpy, it's large, it's wide-based. I would normally inject something to cushion under it and to lift it, saline or a certain material that's gel-like to raise it up. And then if it's removed in pieces, we look at the pathology, and if there is no malignancy in it, the margins are not determined that way because it's removed in fragments. Then if there is no cancer or severe dysplasia, especially also in this, then we bring the patient back in a few months, usually 3 to 6 months, to look at the removal site. And at the time of the initial removal, we usually do a tattooing. We put a black ink dye. We mark the spot with black dye. We call it tattooing, mucosal tattooing. So we go back to the same spot and inspect the scar of that polyp to see if there is any remaining tissue. If there is any question, of the scar is biopsied to see if there is remaining tissue. I hope that answered the question. And if any other panelists want to add to that, thank you.
Well, thanks very much, Dr. Abudh. I know we are a little limited on time, and I think that was an excellent summary for the main question. I think we've taken care of the questions that have been submitted, and so at this point, I want to again personally thank everyone for joining this evening, and we hope that you found the information tonight to be very useful. We do feel privileged to be with you this evening and hope that you consider us and Premier Health for any of your healthcare needs as they may occur. If you would like to learn more about Premier Health's cancer services, you can visit us at the website noted on the screen or by calling the Hope line at the number as well. As a reminder to everyone, this seminar was recorded, and for anyone who is on the site tonight, we'll send a link to the recording in the next several days. And should you want to go back and listen to any of the information. I also want to thank all of our presenters tonight for a wonderful presentation, an excellent overview, and very useful information to all of us about colorectal cancer. We do invite all the participants to fill out a quick survey tonight, or at least about tonight's presentation, because that will help us in planning future events and typical in this forum as we all learn about these various virtual conferences and events. It's helpful to know how people saw and how it went for the participants tonight. There will be a link to the survey posted in the chat section for everyone, and I want to thank you in advance for filling those out. Again, they're very helpful for us in future planning for what we may do next. With that, I want to wish everyone a great evening, and thank you very much.